everybody. It's Vicki here on the next happy hour, and I'm glad to see so many people, familiar friends with us and new friends. Today I see that we have our guest speaker, Ancella Ramjas, who is from the Down syndrome. I'm getting it right. I'm learning her, Ancella. It's a learning curve for me. So I'm looking forward to all that I'll learn from you today. Just a gentle wave and hello. We'll come back to you in a moment. Then we have Sandya Singh. Hi, Sandya.
Hi, Vicki, and hi, colleagues. Yes, thank you. Thank you, Vicki. I didn't have a problem connecting today. I appreciate that. Thank you very much. This was a little bit of a stretch. I started this morning at 7 in the morning, so it's been a long day, but thank you very much for the invite.
Well, thank you for co-hosting, and we're really grateful. And then our dear friend Lucy from Cancer, who is always alongside us. And I heard you all talking while I was trying to fix something. So Lucy, I'd love you to handle the chat this evening, and we'll move on. And Emmanuel, as ever, thanks Lucy, and Emmanuel, as ever, will be in the hot seat. And he will fix if we fall off and fix if we fall on and all the rest of it. So thanks so much from EP Digital. Thank you. He's also a co-host, as is Cancer and as is the Department of Health. So we'll move on now tonight. I want to, without too much ado, because we can get bogged down in all of these discussions. So the purpose of tonight's discussion is to look at a particular group of vulnerable people who are in need of vaccination. And I'm going to share the screen. I hope it doesn't unshare it with everybody else, but it will eventually, I think, work on. So there we go. So this is what we are looking at when we talk about people, and in particular, we're looking here at phase 2 of the rollout. And all of these, except for persons over the age of 60, are open to discussion because we don't actually know what it means. And one of the things that are missing here is a whole consideration of people who don't fall in with the category 18 years with comorbidities, this group here. So it talks about comorbidities, but it doesn't tell us what the comorbidities are, and that's what we've been packing over recent times. It doesn't tell us what congregate settings are and who essential workers are. And so we are focusing tonight on a group of people who may have some intellectual challenges, they have disabilities, and many of them are children. And so for that this classification doesn't tell us what is going to happen, and nor have we had discussion. So I think I now need to go to the next screen. Do you think I can even remember or find out where my next screen is? Oh dear, there we are. And why are we fussing about this? So this is the most recent statistics. The blue line on non-communicable diseases and the percentage of people who die from these illnesses. This is what happened with HIV, AIDS, and communicable diseases. There was a 10-year period where it blipped, but then ARVs came on the scene, and that is what has happened to the death rates. Doesn't necessarily mean that NCDs are going up, but it is certainly showing that it's an important cause of illness. And of course, NCDs are don't necessarily include people with disabilities. The other part here is in many countries, accidents and homicide are added into this group here. They are called these are called non-natural causes, but in many places where we look at non-communicable diseases, these get put in that group and not in that group. So if we actually had to put the reality together, we're talking about a lot of people. And then these are the statistics that came out of NICD, and it shows you age group. And so you can see the smaller circle here shows that under 20 is not a big group of people, but there is still the blue bit in all of these are the non-communicable diseases. And it's showing us very clearly that non-communicable diseases at any age, doesn't matter what age we're talking about, are an important definition of the people who have comorbidities. The trouble is that the data to collect hospitalizations and deaths is very skewed. NCD's data, for example, obesity is not routinely collected. It doesn't show all kinds of things that we need to know. So this is not a good reflection. So all in all, we have a difficult situation here. And that is why tonight we are looking at the Down syndrome, and Ancella will take us through it in two parts. The first part will to be introduced what the need is in terms of her grouping and who she's talking about. And then we will go have a discussion, and then we move on to the second session where we discuss vaccination again. And not again, but we look at what is needed and what has been done internationally about vaccination. This session is being recorded, and so we're very grateful for people that have joined us now, so that we have a growing following in this area. So I'm going to hand over to Ancella. She's going to tell us about herself and her organization, and we look forward to it. Ancella, go for it, girl. Thank you.
Thank you, Vicki, and thank you for this opportunity, and good evening to all the people that have joined this webinar. As Vicki explained, I am from Down Syndrome South Africa, and I am the National Executive Director. I've been at Down Syndrome South Africa now for the past 7 years, and prior to that, I was based at our local chapter. So first of all, let me allow me to introduce you to my inspiration and why I do what I do. My daughter, Ramjas, she's now 24 years old. She's the reason why I am holding this position today. And as I often describe her as my discovery challenge, because everything that I've learned through her, and not the other way around. So she teaches me every single day about myself. So where did the journey for parents such as myself start? So the journey started, you can just enter again, thank you. So the journey started way back in 1986, where a group of parents came together merely to share their stories and experiences on how to raise a child with Down syndrome. And what they realized that there was a lot of information needed. Parents didn't have enough information on Down syndrome and what it took to raise a child. And so DSSA was formally set up as the national umbrella bodies when we realized that there was more support needed throughout the country. Today, we have 12 regional organizations throughout South Africa advocating for the rights of persons with Down syndrome and their families. So we originally started in someone's house over a cup of tea. And today we're based throughout South Africa. What is our mission? Obviously, we committed to finding ways to improve the quality of life for persons with Down syndrome, including intellectual disabilities, promoting the idea that they have a right to live with independence, dignity, respect, and full security as adults and citizens of our country. Vision to ensure equal access, dignity, and respect for all persons with Down syndrome. We hope to be the driver of change in changing public perception around Down syndrome and to empower persons with Down syndrome and their families. There's a lot of myths that surround the condition, and obviously one of our key focus is to raise awareness around that, around Down syndrome. So the areas that we focus on is capacity building of our members. We are a human rights advocacy organization, and we do a lot of awareness in terms of the condition. Okay. Our human rights advocacy is obviously working with government and changing policy at both national and provincial level, thereby changing programs and promoting the inclusion of all persons with Down syndrome in line with the United Nations Conventions on the Rights of Persons with Disabilities. We advocate in all spheres of life, from access to education, access to health, access to employment, access to social and political rights. Awareness in terms of what exactly is Down syndrome. Down syndrome is a genetic condition caused by a full or partial extra copy of chromosome 21, commonly referred to as trisomy 1. This extra chromosome alters the course of physical development as well as causes intellectual disability, and you see it causes certain facial characteristics which is associated with Down syndrome, meaning the small faces, the upward slant of the eyes, small nose, small mouth with large protruding tongues, and also those are the most visible signs that you would see in Down syndrome. You would also find that some of the children will display a single crease on the palm of their hand called the simian crease. There are 3 types of Down syndrome. The most common type of Down syndrome is trisomy 21. We have mosaic Down syndrome, and we also have Robertsonian translocation. It's important to note that it occurs equally amongst all race, religions, and socioeconomic groups. There is no cure for Down syndrome. It is not an illness nor a disease. Their physical appearance does not dictate their abilities. Medical complications that you will find associated with Down syndrome, 50 to 50% are born with congenital heart conditions. They have got the gastrointestinal defects. They have compromised immune systems, sleep apnea, obesity, spinal problems. Some of them do have suffer from leukemia and dementia. And you would see that I actually bolded some of the medical complications, because you'll see how that comes through in the international study that came through in terms of COVID-19 and Down syndrome. It's also important to remember that each person with Down syndrome is a unique individual. So not all these medical conditions will be present in each person with Down syndrome or present at the same time. Where does the name Down syndrome come from? Now, Vicki asked me a very interesting question last week in terms of the why some organizations use the Downs and others just use Down. So the name was given by Dr. John Langdon Down, a British physician who was the first person to formally identify a group of patients with similar characteristics way back in 1866. Prior to this, the term Mongoloid was used, which was found to be very derogatory. In the 1960s, Dr. Langdon Down's grandson formally launched a campaign for the name Down syndrome to be adopted, and the World Health Organization formally adopted it and recommended it in 1965. So Down syndrome is widely the accepted terminology. Now, Down versus the Downs. Well, an apostrophe S connotes ownership or possession. Now, because Dr. Langdon Down did not have Down syndrome, some organizations elected not to use the apostrophe S. Both terms are widely acceptable, although the United Kingdom has chosen to use the apostrophe S, and the United States, South Africa, does not use the apostrophe S. So, Vicki, I hope that has given you some explanation. So, what has been the impact and the response to COVID-19? You know, South Africa remains one of the most unequal societies in the world, with high levels of poverty, low education levels, high unemployment rates, corruption also as well. It has largely contributed to the lack of access to appropriate service and adequate services. The epidemic exposed the inequality of those most marginalized. Down syndrome South Africa, much like many non-profit organizations, was negatively impacted by the pandemic and the downright disastrous response by our South African government for families and persons with disabilities. When the lockdown happened in March last year, you know, areas that we never focused on before came to the forefront. And you know, one of the key challenges that we had to deal with was food security. Distribution of food parcels and vouchers to needy families. So a lot of the distress calls that we got from families was that they didn't have food to eat. A lot of families, remember, who had children that were attending special schools and that were in boarding facilities, suddenly end up with a full house of people and mouths to feed, and they didn't have the means to provide this. So the SSA had to step in and see how we could provide these services. We also had to assist with the registration for distress grants with SASSA for families who did not receive any form of social assistance. There was a lack of information in terms of information being available in an accessible format for families and persons with Down syndrome, in understanding exactly what the syndrome, the virus was, and what were the hygiene protocols. Now, if you know and understand what Down syndrome is and the learning profile of persons with Down syndrome, that they are visual learners. So a lot of the information that you have to provide for them has to be in very simple language, and it has to be visual in order for them to understand. And this is what we needed to develop in order to distribute to families. There was lack of support in terms of educational and therapeutic resources. So parents were left with no support from the Department of Basic Education and the Department of Health. Remember, children were returned from special schools where some of them used to still receive their therapy, and because they were now sent home and all the hospitals and clinics were not seeing patients if it was not COVID related, these children were left with no form of therapy intervention. And so we had to develop resources by placing these resources on and distributing it through WhatsApp groups or video clips and via emails. And we also had to sometimes hand deliver information packs to parents who didn't have access to technology. And so one of the key challenges that we also, found during this period was distribution, in terms that we weren't allowed to be up in the public. So we had to apply for a special permit in order for our outreach coordinators to go out and hand deliver these information packs. Major challenges in terms of treatment and admissions for non-COVID related emergencies, as well as concerns from parents regarding non-contact with their child where admissions were allowed. So a lot of parents experienced severe stress when their children were admitted to hospitals, and that the fact that they could not have contact with their children while they were admitted. We also assisted in the drafting of the guidelines for persons with Down syndrome in terms of the safety protocols to the Department of Basic Education. We joined the Equal Law Education Center in their court bid, forcing the Department of Basic Education to implement guidelines for the return of children to schools with intellectual disabilities. So in the original drafting of the guidelines in terms of the directives for children to return to schools, it was only physical disabilities that was provided with guidelines. So it was so it was important for us to step in, to force the Department of Basic Education to develop guidelines for persons with intellectual disabilities. Many of our children were being forced to stay at home for non-compliance of mask wearing. And these was due to sensory challenges. So a lot of our kids, struggled to wear masks for continuous hours for the entire day, due to sensory challenges. For me, this is personal. Being a parent, I personally seen how the pandemic has negatively impacted on my daughter's life. And this is something experienced not only by me, but many other families. Prior to COVID-19, Tamise had a life surrounded by family. She was in a training program to be employed by the H&M franchise clothing store. She had made friends at her place of work, and her life had purpose and meaning. COVID took all this away. She lost contact with her friends. She struggled to understand why she could not go out to see her family and work at her favorite place. She lost control on making choices of how to lead her life, and this has negatively impacted on her mental well-being. This year is part of our Global Down Syndrome Day celebrations, which is celebrated on the 21st of March each year. And you'll see the date is unique in terms that it represents the 3 chromosomes on the 21st chromosomal pair. So that's the reason why the date of the 21st of March was chosen. The theme for this year that was decided on was the word connect. It was chosen to show how persons with Down syndrome's lives were changed due to COVID-19. This provided organizations a better understanding of the challenges our children faced and what they needed and how we needed to create platforms to allow them to connect and teach them how to cope during the pandemic. DSA launched the virtual self-advocacy platform to bring young adults across South Africa to connect with each other, to make new friends, but also to connect and share their personal stories. So I've inserted the picture of my daughter at the H&M store with her colleagues. So, equitable access and disability inclusive response to COVID-19 for persons with Down syndrome, including the right to vaccinate. And so if we look at the South African context, our constitution is, is the highest law in the country. And our human rights bill affirms that all decisions must promote the common good while respecting human dignity. Every person is considered and treated as having equal dignity, worth, and value when promoting public health. Experience, however, has taught us that this does not often happen when it comes to persons with disabilities, unless disability organizations are at the forefront advocating for change. Persons with disabilities, specifically those with intellectual and developmental disabilities, are often furthest left behind. And this was evidenced in the guidelines that were developed for the return of children to schools. And it says there, according to the UN Convention, that you need to start off with those furthest left behind first and ensure that they have equitable access, prior to anybody else. The SSA, like many other organizations across the world, expressed concerns regarding the vulnerability of persons with Down syndrome during COVID-19, and that our children would be discriminated against in terms of the triage protocols when accessing treatment.
People with Down syndrome used to be considered that they would have a shortened lifespan. What is the situation in South Africa and globally about how long people with Down syndrome live now?
This is now considered one of the myths, but I think, medical intervention is greatly ensured that our kids can live longer lives and lead a better quality of life through all the interventions that is made available today. So the average age for persons with Down syndrome is around 60, and this is globally around the globe as well. In South Africa, our oldest person, we just celebrated his birthday at the beginning of April, and he was 65. So
that's wonderful.
Yeah,
wonderful.
And our oldest one that passed away about 4 years ago was actually 74. And yes.
Before we go, thank you for that, because that's one of the things we grew up with the shortened, but I'm old, so, it was before a lot of the interventions.
Yeah.
And then if you can just tell us about statistics and people with Down syndrome. I know that there have been questions about how many, where are they, et cetera, et cetera. What can you tell us about statistics and Down syndrome?
When in your previous slides, you mentioned that data is a problem in South Africa, and this is also the same in terms of Down syndrome. We average that the incidence of Down syndrome is between 500 to 750 live births in developing countries. But in terms of actual data of the real numbers of children born with Down syndrome, it's very difficult to get that information in South Africa. So we will only know of a birth once parents make contact with us. I see that Dr. Hani has joined us now. Dr. Hani is very well known in terms of her work with, Down syndrome, with babies with Down syndrome. There's not a child in Gauteng that she hasn't worked with. So I don't know if Dr. Hani would like to come in and maybe give, more explanation around that.
Hi, Dr. Hani, can you join us?
I am joining you. Hello. Yes, as Ancella said, I am a pediatrician that's trained further in medical genetics, but I'm basically helping with the counseling, coordinating the care of the children, not Gauteng only, but in Pretoria. I also see referrals from Limpopo, Mpumalanga. We are trying to see if we can give a service. So that is basically what I do.
Would you like to add something to what Ancella is saying, or the questions that I'm asking, or something that's important that you think we should be thinking about?
I think what is very important, if you look at Down syndrome, is the comorbidities that we see in individuals with Down syndrome. Also, their immune status is compromised. They do have an altered reaction. And that's why, you know, I think Down syndrome per se is going to be, you know, a prerequisite to expedite vaccination in children and adults with comorbidities. So she referred to some studies. I also looked at some of the studies. It's not, you know, that I'm sure the parents and individuals were protected with social distancing. And I know in our setting, a lot of parents didn't send their children to school specifically because they were forewarned about the effects of COVID. So I think they do also make precautions. So we didn't get, you know, a massive outbreak of patients with COVID-19. I personally didn't encounter anyone. I heard of people that did actually have, you know, COVID. But I still think precautions is very important.
So we've got another group of people that vulnerability is not necessarily the same thing as comorbidities. And also children are part of that grouping that we're talking about. So thank you very much. Before we get back to Ancella, can we hear from Sandya Singh from the Department of Health, just your comments briefly, if we may, Sandya.
Thank you, Vicki, and thank you to Ancella. And yes, you know, from our side, the Department of Health fully understands or appreciates the difficulties experienced by the disability sector, and we are very we're acutely aware that many of their challenges are not being met, and we're not finding solutions for their challenges at the moment. And largely, my observation is that we need to improve coordination, collaboration between the sectors that deal with persons with disabilities and their families. I think we must be very clear that we cannot ignore the context from which the persons with disabilities come. And many of them don't have families, but they have caregivers, and many of them live in communities, and we need to understand the context in which they live and the context in which we are aiming to address their needs. We've all been privy to the minister's announcement around the phase 2 vaccine rollout. We are told, we are informed that this is going to be age-based, starting with 60 plus, and then moving down to lower age bands. So at this stage, it appears as though in phase 2, which is envisaged to start on the 17th of May, there appears to be very little flexibility in terms of including other groups at the moment. However, I'm sure this there could be changes. We have been observing many amendments and adjustments to plans. And at this stage, we want to start, or the minister has announced, the priority group will be 60 plus. caregivers at all congregate settings, and these are facilities that where persons with disabilities, mental health care users, and older persons reside, as well as essential workers. And at this stage, there is some discussion about the age for the essential workers. However, it appears as though it might be 40 plus from what we've observed in the announcement. But in terms of commencing the phase 2 program, we would be starting with 60 plus and then move down to 50 and then 40. So many of these decisions were based on available resources, and that being available vaccines. So we would need to be very cognizant that many groups who have submitted input, very clear input, evidence, unfortunately, it looks like the decision that was taken in terms of the most feasible way forward would be to go by age bands, and that's what the ministers has announced. I think that we do need to look at protection, shielding and protection of persons with disabilities. We've been very impressed with the work done by MSF, and we are trying to expand that coverage in terms of identifying within communities who is vulnerable and who needs protection. So even though those persons may not be vaccinated immediately, our intention is to ensure that we at least expand the scope of shielding and protection. And there's going to, the Better Health Program will be hosting a webinar on shielding and protection. I think it's on the 29th of April. And Vicki, you were on the invitation list. So we've got to make the best of what the situation is at the moment. And what the situation is that in the absence of immediate vaccination for persons with comorbidities and persons with disabilities and persons who are mental health care users, we've got to look at how we protect them in the interim until those populations are vaccinated. And it is our view that the Shielding and Protection Unit, which does not demand excessive resources and should not be seen as something that occurs outside the health service, must be strongly considered in all districts, and that we need to ensure that all stakeholders, including groups such as the South African Disability Alliance, the palliative care group, are all informed and collaborate on this project.
Thanks so much, Sandya. We are running out of time, but what I hear you saying is that the policy is to deal with age first as the one predictor that we can measure without going into a lot of hassle and other definition. And it is the data that has been collected best is around age and that mortality and morbidity. And then after that, because as we have constrained resources, what we're going to be looking at is shielding. So for the third wave, which is likely to start within the next month or so, we are looking, the next 60 days, we are looking at shielding. And I think that needs a whole program on its own, and maybe we can facilitate doing with MSF and a group of people how we do that better. But shielding really means doing what we've been doing for so long, but carrying on doing it in not an expensive way. And how do we do it with people who don't have much space, many facilities, etc., etc. So thank you for that. I'm going to ask I'm sorry, Ancella, we are running out of time for you, and I apologize greatly. Could you summarize the findings that you had? And we ask if you could just summarize so that we make sure that we've got the information from overseas and what's been done in other settings apart from Southern Africa. So thank you, Ancella.
Okay,
Apologies, but you have
no
lots
problem.
of support.
Thank you. Thanks for that. I understand totally. Emmanuel, if we could go back to the slides, I'll just tell you which slides maybe to. You know, there was research undertaken by the Human Rights Commission in terms of the impact of COVID-19 on persons with disabilities. And, you know, one of the challenges and one of the key things that came out from this is obviously poverty, where families were not able to purchase preventative materials needed to prevent the spreading of the virus. Most of our children live in crowded dwellings. They also live with elderly parents, and some even are being cared by, where there's no parents, are being cared by the gogos, which are also prone to and at high risk of the virus, meaning exposing you know, the younger kids with Down syndrome to the virus. Our children are dependent on others to take care of their personal needs. You know, and one of the concerns also is that, you know, our hospitals are facing, you know, is in crisis in terms of having adequate staff and life-saving equipment. I did speak earlier on the sensory challenges with regard to mask wearing. Communication seems to be also one of the key problems. Our children generally struggle with communication in the wearing of the face mask, which further hampers their ability to communicate, unable to understand preventative measures and communicate their symptoms of illness. And we need to point out that this was evidenced by the death of Renee Andrews, a 15-year-old girl who died, girl with Down syndrome who died all alone at the Helen Joseph Hospital in August last year. And her parents were only informed 2 months later of her death. And this is because this little girl entered the hospital all alone, was not able to communicate her illness, was not able to make contact with her family or speak to her family. And I think the stress levels in being in an environment that was unfamiliar to her, she did not understand what was happening to her, could have led to this little girl losing her life. And so we need to bear this in mind, you know, in terms of our children. The international group undertook a study, and it was primarily done by the Trisomy 21 Research Society to understand the risk factors, you know, and make recommendations in terms of Down syndrome. The studies you will see was also published in the Lancet eClinical Medicine. The collected cases, there was 1,000 cases collected from around the world. So what they did was they took, and these are only persons who contracted COVID-19. What they did is they took about 100 cases of persons that were admitted to hospital and compared it with about around 400 cases of persons without Down syndrome, based on the age, same age, ethnicity, and gender. And what they did, they compared the results, and the collected results were provided by carers and clinical professionals. Okay, so those were some of the stats that came out of the study. From the 146,000 sample study tested, these were all cases where they tested positive for COVID-19. The largest number of cases was reported by India, followed by the US, Spain, and Brazil. I just watched the news before I came into this meeting. In India had around 315 positive cases now in the last 24 hours. So it's understandable why that the largest number came from India. Most of those reported lived with families. Risk factors that was linked to hospitalization was age, obesity, congenital heart defects, and diabetes. Half of the cases, about 581, were admitted to hospital. 279 were admitted to the ICU. 207 were connected to a mechanical ventilator. So and 131 of those people died, so it's not a very big number. And what they found is that most of them died of viral pneumonia and acute respiratory distress syndrome. So the question was whether individuals with Down syndrome are more vulnerable to severe outcomes because of co-occurring conditions. The risk factors that they found was similar to the general population. So it was age, diabetes, congenital heart defects, obesity, dementia, renal failure, sleep apnea, and acute respiratory infections. They show the same symptoms as the general population, but what was important to note that that while the general population, the risk to severe outcomes increase from the age of 60 and above, in persons with Down syndrome, it comes more pronounced from the age of 40. So therefore, when Sandya speaks about that, the current rollout strategy only speaks of persons 60, you could see that persons with Down syndrome, I mean, it presents at around age 40 already. In the study with children and COVID-19, there wasn't really much research around this, but what I did do was take the stats that was provided by the Center for Disease Control in the US, and they compared this data with other countries and found that the risk factors for children was obesity, thyroid disorder, and epilepsy. Mortality rates was higher in lower to middle income countries, due to the lack of capacity and lack of resources. If children were hospitalized, it was due to the immune dysregulation and anatomical airways features. Now, children with Down syndrome have, as I explained in the beginning, have small spatial structure. They have large tonsils, small jaws, relatively large tonsils, along with lax throat muscles, which puts them at higher risk to respiratory infections. Mortality rates for children was due to viral pneumonia, acute respiratory problems, and acute renal failure. Okay. The summary was that children with Down syndrome are more vulnerable than children without Down syndrome, but it was less in adults with Down syndrome. Okay. What they said is that we need to pay close attention to their pre-existing comorbidities and immunological status. Sorry about that. Whether response to current vaccines and side effects profiles are different from other people. According to the Down syndrome interest medical group in the US on the safety of vaccines for persons with Down syndrome, they recommended that it is safe and the vaccine should be administered to persons older than 18. They did not recommend it at this stage for children younger than 16 because there wasn't actually any studies yet done on this. And also because children with Down syndrome were not included in the vaccine study. So DSA's position, based on the international research and also based on the concerns raised by parents, we as Sandya explained, we know that our children are unlikely to receive the vaccine soon. But what we like to point out that it is, she speaks about shielding and prevention, protection. It's very difficult to be able to explain to our children about the preventative measures and the safety protocols that they have to follow. And you can see this with the mask wearing and where they've been told not to come to school anymore because they are regarded as vulnerable. And, shielding takes away your independence. It deprives you of a livelihood, and it definitely has a negative impact on their mental health. And so our position is that we do feel strongly that our, at least our young adults should be prioritized in terms of vaccination. It is important that we also provide the facts to our parents so that they can make an informed choice whether to vaccinate or not. In conclusion, all I can say, healthcare can neither be universal nor equitable if it is less accessible to some sections of society than it is to others. If my daughter can exercise her right to be vaccinated, she would be able to return to a life that she so loves. My needs are not special needs, but human needs. And as my daughter would say, my life matters. Thank you.
Thanks so much, Ancella. I'm sorry we have.
Sorry, I had to rush through that, but sorry.
Thank you so much. I wondered if Dr. Honey, if she's still here, if she's got any words. I don't. Any comments on that, Angela?
I can only totally agree with Ancella. I do think that we should try and prioritize. As I said, we have the people have the rights, and internationally, I think they are coming on board to vaccinate adults with Down syndrome from the age of 40. And I think we should also do that.
So thank you so much for joining us. This will be up on our YouTube channel. We're going to ask Velile if he's there to offer a closing comment on all of this. Velile, are you able to, you've written something in the chat box, are you able to give us your comment live?
Okay, so just a quick comment. Thank you so much for sharing all this very useful information. So my concern, I think I had made the comment around the fact that obviously I think whatever decisions are being made are based on evidence that we have within our setting, because we have been collecting the data on hypertensives, the overweight patients. So generally that is what's informed us. And I think the fact that we have not been collecting data like what's been discussed on people living with Down syndrome, I think is a big disadvantage. But I was just commenting also on the study that was presented, that study, the conclusions don't seem to make a case for a prioritization of people living with Down syndrome above those individuals with comorbid conditions without not living with Down syndrome. So that was just my feeling from the study, that I think maybe what it looks like that our best bet is us maybe tying up people living with comorbid medical conditions that have been proven to increase risk, which is what they have in common with people with living with Downs. And I think that would have been our best bet. But I think the challenge that the department had faced, because I support KZN in the COVID-19 response, and I've been with them in the discussions as well, is that I think it becomes very difficult to then prove comorbid medical conditions when we're having to go into a regional level and having to deal with individuals. So it became easier for them to just stick with over 60 to try and catch as many of those as possible. Unfortunately, in that process, then you lose a lot of young people, because I think the case that I had also raised was that you have young people up less than 40 who have comorbid medical conditions, who are highly economically active, and in an environment where we are faced with a struggling economy, and some of those might actually even own companies and employ a multitude of individuals. So there's a huge case for looking at comorbid medical conditions under 40, but I think the reality is that we are under a disaster type circumstances, and I think the idea is to use the easiest criteria to be able to then just move as quickly as possible forward, and I think that's where we're going to lose. But I think I just wanted to say that the conclusions don't seem to help our case in lifting people living with Down syndrome above those individuals living with comorbid medical conditions under 40 years of age. Thank you so much.
Thanks, Velile. Ancella, would you like to make any comment on that?
I think that said, we have to make that, go according to that, because, the research is there, the evidence is there that they are vulnerable, and they are, it says that they, if hospitalized, they are 10 times more likely to die. And I think we should do everything in our power to try and persuade the decisions that our kids, at least above 18, should be considered. I mean, so India has gone ahead now and prioritized, adults over 18 to be vaccinated.
Thank you so much, Ancella. And I know this is heart-wrenching for you as well to hear that. But what I would like us all to remember as we close, and thanks Ancella and to Sandya and Velile for all of the contributions. What I'd like us to recall is that we don't have information and statistics relating to non-communicable diseases and disabilities in South Africa. They are badly collected, poorly collected, and we have no vision of the burden of evidence. It just happens that age is the most convenient one to hitch our post to. And so we don't measure most of them. We don't measure obesity. So let's say it's enough for tonight. We've opened the door to discussion. Thank you so much. And Sandy, if you can switch your picture on, and Lucy and all the rest, and Angela, and let's just wave goodbye. This will be up on the YouTube channel. Sorry, Lucy, we didn't bring you in. We'll see you anon. And hello, everybody. Hello, Bususi. All of you so nice. Goodbye. Have a lovely evening. It's on the YouTube channel. Spread it with everybody. And thank you for your time and energy. We're getting lots of YouTube hits. So it's not a waste today. So thank you. Bye-bye.
Thank you very much. Thank you, Vicki. Thanks for having us. Thank you, everybody. Thank you. Good night.